the 2025 Child Safety Link Webinar Series. I think we'll get started. I know we'll have some more folks joining us as the time goes on, but I just want to be timely and make sure we have enough time for Claire to tell us all of the things. So my name is Mallory Cornelius, and I am a health promotion specialist with Child Safety Link, and I will be moderating our webinar today. And we would just like to begin by acknowledging that we are in Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people. We are all treaty people who benefit greatly from the shared resources of this land covered by the treaties of peace and friendship. I would also like to address a few housekeeping items before we begin the presentation. The presentation will be recorded and it will be available to view a few days after this session. It takes us a little bit of time to get it up, but it'll be available on our website. We also ask that you mute your mics and keep your cameras turned off during the presentation. And lastly, if you do have questions during the presentation, please put them in the chat box. My colleague Sarah will be monitoring them, and there will be time at the end for questions, and you can turn your mic on at that point if you want to ask the question or provide it in the chat box, whichever is more comfortable for you. I would also like to provide a very brief summary of Child Safety Link. We are an injury prevention program at IWK Health dedicated to reducing the incidence and severity of unintentional injury to children and youth in Atlantic Canada. We are committed to working with community organizations, governments, and other partners to ensure children are as safe as necessary at home, on the road, and at play. Our at-home work includes poisoning and falls prevention. Our on-the-road work includes child passenger safety and pedestrian safety. And our at-play work includes helmet safety, concussion safety, and ATV safety. So I would now like to introduce our presenter for today, Dr. Claire Benny. She is an assistant professor in the School of Public Health at the University of Alberta and the scientific director of Alberta's Injury Prevention Centre. A social epidemiologist by trade, Claire has research interests in the social inequities underlying injury risk and severity. So I will now hand it over to you, Claire.
Okay, that's excellent. Thank you so much. Great, so I'd love to get started today. As Mallory mentioned, my presentation is on social determinants of injury-attributable emergency department visits in Canada. We can go to the next slide. I'm going to just quickly acknowledge the land where this work was carried out. So this presentation and the studies detailed in this presentation were created on Treaty 6 territory, which is traditional gathering place of diverse Indigenous people, including Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories and languages and cultures influence our community. Great. But today I'm really happy to be located in Pictou County, and I'm presenting from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. And I'd also like to acknowledge Nova Scotia's 52 historic Black communities who have been in Nova Scotia for over 400 years. So just sort of a brief outline of what I'm going to be chatting about today. So I'm going to give a brief introduction to injury in Canada. So what is injury? How common is it? And sort of the most common types of injury. I'm going to be talking about how we measure injury in research. I'm going to be discussing 2 case studies on social determinants of injury attributable emergency department visits. So this is recent work that my team has been carrying out. And finally, I'm going to talk about some policy and public health implications. So injuries in Canada, why are they a big deal? Well, they're a leading cause of death and disability in Canada. Injuries are predictable and they are preventable. Rates have remained steady over the past 2 decades, but still represent a relatively high public health burden. Next slide, please. So what is an injury? Well, it's damage to the body. It's something that results in disruption to our normal functioning. Now, when most folks think injuries, they might think things like falls and scrapes, motor vehicle collisions, right? Injuries resulting from these sort of events. Next slide, please. But injuries include a really wide variety of health outcomes. So they vary greatly. In fact, some mental conditions can be referred to as stress injuries or moral injuries when something sort of goes against your ethical code or your moral code, right? And it sort of disrupts your bodily function. It can be sometimes noted to be a wound to our emotional being. But what I'm really trying to get at here is that injuries are diverse and they come from a number of different sources and mechanisms, and our injury risk is shaped and formed in so many different ways. Next slide, please. So the types of injury are typically categorized into two different types. So we have our unintentional injuries, which is what groups like Child Safety Link really work to mitigate. So unintentional injuries might arise from falls, motor vehicle collisions, collisions among vulnerable road users such as pedestrians or cyclists, burns, poisoning, drowning, things like this, right? Whereas intentional injuries have some sort of purpose to them, right? Someone is either inflicting pain on someone else or we're inflicting a wound onto ourselves. So these are outcomes such as self-harm and assault. Next slide, please. So the top three leading causes of injury in Canada include self-inflicted injuries, unintentional poisonings, and motor vehicle incidents, so those arising from collisions. But among children specifically, unintentional injuries are the leading cause of death in Canada, and self-inflicted harm is the second leading cause of death amongst youth aged 15 to 19. So this is a really important public health problem, specifically for Canadian youth. Next slide. So when we're measuring injury, there are typically two ways that we can go about it. So we would use self-reported data, things like surveys, questionnaires, focus groups, to get to know just a little bit more about the context surrounding an injury based on someone's recall of an injury event. The second way that we access this data is through administrative data. Now, this is data that's not necessarily collected for research, but as researchers, we're typically able to harness, can be really rich and interesting data, but often lack some of that sort of contextual information that we might get from understanding a person's experience with an injury. So in terms of administrative data, we might have things like walk-in clinic records or physician notes, things that that people might report during a clinician visit, but not necessarily resulting in an emergency department visit or an inpatient hospitalization. Now, these are typically thought to be a little bit less severe, right? Because it's not warranting hospital care, right? The second another aspect of measuring injury would come from emergency department records. Now in Canada, we have a collection of emergency department records or repository called the National Ambulatory Care Reporting System. Coverage across Canada is not necessarily the best, as not all provinces are actually mandated to submit their data to Statistics Canada, and that's how I personally access my data. But emergency department or injuries resulting in emergency department visits are typically fairly severe, but not necessarily warranting an inpatient hospital stay. So we might think about things like a broken leg that doesn't require surgery, for example, would be something that might result in an emergency department visit, right? So more severe than those injuries that don't necessarily require hospital care, but still severe. Um, so third would be hospitalization records. Now these are records resulting from inpatient stays, right? So if you've been admitted to the hospital, then you then have a hospitalization record. So we capture diagnosis codes in each of these record systems to identify different types of injury, which is really useful for research, but not necessarily perfect. With that being said, hospitalization records tend to capture more severe injuries compared to emergency department records or physician records from, say, walk-in clinics or urgent care. Now, what can be known as one of the most severe consequences of an injury event would be death, right? So we can use Canadian vital statistics to track death trends, causes of death attributable to injuries, amongst other things. And while I believe that some folks do consider, oftentimes disability to actually be sometimes more severe than death, right? Depending on the impact that it has on a person's life. In the data, death is typically considered sort of the most severe consequence of an injury. So these are just all different ways of measuring injury and reporting injury, recording injury, and of course there are others. But this is sort of what's most typically seen in the injury prevention literature. You can go to the next slide. Now let's talk determinants of injuries. So this is sort of my area of expertise. Now determinants of injuries are really diverse. It really depends on, the injury mechanism and the context in which an injury occurs. So injuries might be caused by aspects of our built environment, such as, bumps in the sidewalk or a lack of street lights, things that really contribute to the physical environment around us. Now, injuries are often thought to be a product of behaviors, right? So we use behavior change models a lot in injury prevention programming in order to sort of get a person to contemplate changing a behavior in order to reduce the risk of injury. So these might be different risk-taking behaviors, right? So whether you engage with certain sports, whether you use substances, right? So whether you use recreational drugs, for example. This could even be things like, the activities that you do in your daily life. So your job, right? And what you do in your job and whether you're safe, right? So are you wearing your personal protective equipment? Are you only accepting work that is safe for you to perform, for example? Another determinant or an aspect of injury, risk, and severity is, of course, policy, right? So we see a lot of examples in different communities of traffic calming as a means of reducing risk of motor vehicle collisions. We have different helmet policies, whether we require just youth, for example, to wear helmets when they're on a bicycle, or whether we can, ticket and enforce, different bylaws for say adults as well, right? So typically, in sort of the vulnerable road user range, we'll see more policies that are sort of directed towards children. So, for example, on ATVs, you're not supposed to drive them until you're 16. So there would be policies, there might be tickets, there might be fines associated with that sort of behavior. Similarly with helmets, if you're not wearing a helmet and you're on a bike, it's not necessarily the child that's going to be ticketed, but it's likely their caregiver or an adult who's present with them, right? So these are different ways that we can sort of enforce safety policies, but the degree to which they're enforced and the sort of breadth that they actually capture really varies depending on the area, the policy, and the context. Next slide, please, Mallory. But what I'm here to talk about today is something that's really near and dear to my heart, and this is the social determinants of injuries, right? So this is beyond sort of the built environment, beyond our risk-taking behaviors, beyond policy that informs, our injury risk and severity. What are aspects of our social environment that contribute to our risk of injury and how we get better post-injury? Next slide, please. So when I talk about the determinants of health, I am sort of loosely referring to this diagram and many others that capture the same sort of context. Now, this diagram itself is from the World Health Organization. So it's a model of structural determinants that contribute to social determinants of health inequities and also determinants of health, right? Health themselves. So if we consider health inequities to be maybe more systemic or more larger scale disparity in health problems, in social problems, and things like that. And we can consider health to be those things that are immediately impacting our health and not necessarily on a contextual scale. So what I see when I look in at this diagram is really a cycle. All of these aspects are interconnected. The arrows are going this way, that way, and all around and such, right? So we know just based on based on the literature in public health and other disciplines, that things like our government and our politics and social policies, public policies, and not only these, but also our cultural and societal values, social norms in and around the way that we work and live and play. These all have an impact on health inequities, but they also can have sort of a downstream impact on our health themselves. So each of these aspects contribute to our socioeconomic position, which is essentially the relative position that we might hold compared to others in a society, right? Now, our socioeconomic position is typically informed by our social class, by our gender, by our ethnicity, right? By our level of education, what we have access to, what we take from that, right? Also our occupation and our income, and a variety of other factors that can sort of inform where we sit in society relative to others, and also just sort of how we're able to live our daily lives, right? And sorry, so the next part of this, and this is all sort of intertwined, right? And so I am just going to speak through this, and I know it's a little bit long, but I promise I could go longer. So the next aspect of this is what contributes to our social determinants of health, not necessarily systemic health equity circumstances. These are things like, where we live, if our house is safe, right? Is it crowded? Are there too many folks living in our home, right? These are things like food insecurity. Are we able to access the healthy and nutritious food that we need to carry out, our daily life to the best of our ability? These are also biological factors, so our genetics that contribute to different risks of health conditions and things, and also psychosocial factors, so our mental health in general, and where we sort of, how we feel about ourselves just generally. Now, each of these aspects has an impact on equity and health and well-being. And this is also the same for injury, I would argue, right? So each of these policies, the social norms around us will inform whether we are at risk for specific injuries. For example, if we are in a farming community, we might be at more risk for injuries that are associated with farming equipment or agriculture, right? Whereas, and if we have different occupation, right? If we're in a blue collar job, we might be at risk for some injuries versus others that might be more common, maybe among more stressful, like, typing at a desk or managerial positions, right? That really, really can sort of get at your brain. And these are things, like that impact our daily lives, regardless of what sort of career you hold. Because it's not just about you, right? It's about your community, it's about your family, it's about your partner, your friends, and who you surround yourself with that can really dictate where we sit in our life, the opportunities that we have, our life chances, our life choices, which all contributes to our risk of a myriad of injuries, right? And the same can really be said for children as well, right? So I acknowledge that this talk is on Child Safety Link. And so we do need to consider how our social environment impacts our children, right? So, if you have a child, your child doesn't have an occupation and your child doesn't have a marital status, right? Or, well, they do, but likely never married, right? And so your child doesn't have an income, but each of these things and the politics in our society impact children firsthand, right? So when you're a child, typically your socioeconomic position is reflected by your parents. And this is a cycle that's sort of perpetuated over generations, right? And it can be sort of hard to break through, right? And get yourself into a quote unquote better position. And yet there's still the politics and the social norms that shape, how we turn out, right? And so it's sort of my belief that injuries result, yes, of course, because of behaviors, because of, sometimes genetics and sometimes other psychosocial factors, but are also very much shaped by our social environment and the ways in which we were raised and the ways in which we grow up. And that will impact the choices we make throughout our life, and thus our behaviors, and thus our risk for a number of different conditions. Next slide, please. So what has been done on social determinants of health, right, as it relates to injury? So there have been studies, right? A lot of this existing literature was done, or was this research was conducted in the late 1990s, the early 2000s, and these works just sort of generally found that social factors influence injury risk, and this is the same holds true for children. We know that socioeconomic status has an impact on children's injury risk. But if all this is based on the late 1990s and the early 2000s, then I'd urge everyone to consider how our social environment has changed, how our social determinants of health have changed over the past, 30 some years, and also how the nature of injuries, the mechanisms of injuries, and the commonality and the cost of injuries has changed so greatly, but also our knowledge and our injury prevention tactics. And I know we're getting more efficient and we're getting smarter, and yet the risk of injury and trends of injury sort of remain the same over time. And so this leads me to believe that there's maybe a piece missing, and maybe that piece is in part owing to our social environment and social inequities. Next slide, please. So the gap in the literature that I attempt to fill in my work is that there is a lot of recent studies done on social determinants and injuries. And I really do think that we need to update the literature based on our current social environment and the nature of our injuries, right? There's a really limited understanding of why social determinants impact risk, and specifically in terms of the severity of injuries, right? And it's also sort of unclear how social policies, so those that might not necessarily seem related to injury, right? So they're not things like, wearing a helmet or traffic calming, but other sort of outside the box thinking, how those social policies can impact injury outcomes potentially. And so this is where I see there's sort of a gap in the literature that my research aims to fill. Next slide, please. So when we think social determinants of injury, what we need to understand is that injury is not distributed equally, and that different folks will experience injuries differently and at different rates compared to others. So for example, we've always seen major gender disparities in injury, and this totally depends on the injury type, right? So for example, we might see more motor vehicle collisions or more violence, particularly among men and between men, right? But we also see higher rates of self-harm, for example, among women compared to men. And these are just really important contextual factors that we need to consider when we're doing injury prevention programming. We also know that there's great inequality in this world in wealth, and there's high rates of poverty or relatively high rates of poverty, which absolutely impact a person's, propensity to get better post-injury, right? So are you able to take time off work to recover post-injury? And if you experience an injury, who's going to cover for you? Things like that. And these are things that we might think about when we're thinking about more rural communities or these really niche jobs where you don't necessarily have someone to fill your role if you're unable to attend work owing to an injury, for example. So we know that there are folks that can afford, all of the prescriptions, all of the physio, all of the psychotherapies, all of the chiropractor, appointments that come with an injury. And that's not equal. And those things, they are expensive, right? We also know that race and ethnicity can play a major role in injury outcomes, right? And your risk for injuries. So typically we see that certain communities have higher risk of injuries. If we think about, for example, First Nations communities, specifically within Alberta, we might consider that they tend to have higher rates of some injury outcomes, and that's not fair, and that's not distributed equally, right? And so we need to sort of understand some of the nuances here and why these differences come to be. Now, in terms of immigrant status, this is also typically associated actually with a decreased risk of injury, right? But multiple studies have shown that within different immigrant types, that some types, right, experience increased risk of injury. So for example, if you compare refugee, like folks who have sought refugee in Canada compared to, say, someone who is an economic immigrant, then you will see stark differences in injury risk profiles, right? And so it's not necessarily just comparing immigrant to non-immigrant, right? And those sorts of things. It's definitely more nuanced than that. And there's a great body of research out of Ontario that speaks a lot to this. And yet again, we see the same things among youth, right? The results are sort of consistent. And that's because our socioeconomic status and our risk profiles are likely similar to that of adults, right? And so this represents like a really critical health problem, but also a social problem. Now we think about education, it once again, it truly depends on the injury type. And you'll hear this sort of again and again throughout my presentation is, well, it depends, right? And it depends on your injury type. Maybe if you have higher education, you've maybe seen more injury prevention things without even knowing it, right? But maybe in some cases, if you have a higher education, you might have a higher propensity to be in a certain work environment that contributes to stress, that contributes to risk of injury, for example. And so sort of works both ways, and we have to work through those nuances in order to better understand social determinants that underlie injury risk. And finally, income. So once again, I'll speak to those inequities in wealth and whether you're actually able to take time off work, but also whether you're able to access, once again, those physiotherapy sessions and those other things that occur post-injury. And it's not only this, but it's also, if you are, for example, someone who's lower income and tends to rely more so on public transit compared to having your own vehicle, for example, and it's really cold and environmental injuries are so common, things like frostbite, things like, overheating and heat exhaustion, sun poisoning, right? Those are all sort of environmental injuries that are really damaging to our health. And if you are someone who's outside and exposed to that more so, then you're going to be at a higher risk for these things, right? Compared to the person who's maybe stuck in traffic a little bit too long. And then the flip side of that, of course, is that that person then is at an increased risk of motor vehicle collision. So it's really just this sort of vicious cycle where we're trying to understand some of the nuances that underlie our injury risk, and just something that's particularly interesting to me. Next slide, please. So in terms of social inequities, these inequities are really shaped by, the places where we live. How far is it to the nearest hospital to receive care? Or what's your sort of like, what's the cultural norms around accessing care? Or what's the cultural norms around actual safety and personal protection equipment, wearing a helmet, driving an ATV underage, for example? It also has a lot to do with our built environment. So more socially unequal areas tend to have less investment into infrastructure in the built environment. So for example, fewer street lights, right? These are all aspects that contribute to maybe whether we're going to fall down at night because we can't really see where we're going particularly well, or even just the safety of our streets in general. So we see that child health, right? Children are at an increased risk of a multitude of injuries, and this might be simply owing to inexperience, but this is also just, the ways in which we play and the social norms around us, the ways in which other kids play, that all sort of influence, where we are in our life, right? And what we're going to be doing in our life choices, chances, once again. So our occupation absolutely has an impact. If you're a firefighter, for example, you might be at an increased risk of burns, right? But not necessarily other outcomes. And so these are, yeah, once again, just sort of examples of things that contribute to our injury risk. Also, the sports we play, whether they're higher impact, things like team sports versus solo sports, what kind of equipment is required in our sport that keeps us safe. These are all aspects that contribute to our injury risk and severity, as well as those around us and what they do, right? Because we're all sort of creatures of habit, and we're always sort of comparing to see what other folks are up to and whether it's okay for us to sort of do the same thing, right? We're social beings, and we do sort of sometimes we do as we see. Other aspects such as stress, right? Stress among children contribute to injury risk, and just generally stress is very impactful on our health. And so it's not just injury risk, but it's just about everything in our lives. Also the environment and the ways that different exposures can change our health, right? So whether we're always inhaling wildfire smoke, for example, whether we're always, really getting the heat's coming down on us, or it's really cold and we're more prone to frostbite and other things, how exposed we are to the elements, for example. And once again, education, right? And the how we do in school, but also the stress that school brings us, and once again, this sort of multifaceted idea that all of these aspects contribute to our health and ultimately our injury risk. Next slide, please. Okay, so I'm going to talk through now two case studies that we've done recently related to injury attributable emergency department visits. So the first study that I'm going to talk about, it used the Canadian Census and that National Ambulatory Care Reporting System from 2016 to 2023. So this sample included Canadians aged 15 to 64 in the year of 2016, who were then followed up over time to see if they incurred an emergency department visit attributable to an injury. Now, we did have to limit our sample to Alberta, as that's where my research lab is located, but also, as I mentioned earlier, emergency department record coverage isn't as high in some provinces as it is in others. So in Alberta, it is mandated that emergency departments must report their emergency data to Statistics Canada, and so that data is widely accessible for us in Alberta. So that brings our sample to about 3.1 million respondents or folks. Next slide, please. So why are injuries important in the Albertan context, right? So we need a justification for why we're limiting our sample just to Alberta, and interestingly, we really have one here. So annually, injuries cost Albertans about $7 million per year, with $5 million of that being attributable to healthcare costs. Now, in 2025 alone, thus far in the year, I think that we've already, Albertans have already incurred costs close to $6 million, right, attributable to injuries. Now, this actually represents about 25% of Canadian injury attributable costs, but Alberta only represents less than 12% of the Canadian population, which represents sort of a disparity in our injury risk per capita. Next slide, please. So this first study looked at individual level social determinants of health and injury attributable ED visits in Alberta. Next slide again. So once again, we used the census that was linked to the emergency department data. We weighted the sample to represent all Albertans rather than just those who did fill out the census. Next slide. So measures that we use to approximate social determinants of health included income, education, gender, marital status, immigrant status, ethnicity, and then of course we included age and year and things like that into our modeling. But in terms of sort of the social determinants of health, this is what was included, and that's what we're testing to see if there's increased risk of emergency department visits attributable to any of these social determinants of health. Next slide. So the injury outcomes that we included for the study were unintentional injuries. So those injuries including falls, burns, poisonings, drowning, motor vehicle collisions, and off-road vehicle collisions, off-road related injuries. Next slide. We also looked at intentional injuries, so again, those including self-harm and assault. Next slide. Okay, now this table, I know no one loves to see a table in a presentation, but I am just going to sort of quickly summarize this for you. So what we see for income is that relative to low income for unintentional injuries, it seems that there's actually sort of an increased risk, right? And again, I just want to preface this by saying that this is sort of an overarching category of injury. And on the next slide, I think I have actually some examples of priority injury types. But what this is sort of showing is that if with higher income, there's an increased risk of unintentional injury, we sort of have to ask ourselves the question, what injuries are driving this result, right? Because not all injuries are necessarily socially patterned in this way. If we take concussion, for example, concussions primarily what may occur due to sport, right? And sport is not necessarily equally accessible among all groups, and so those participating sports may tend to be a little bit more affluent compared to those who are unable to attend sports or unable to participate in sports, or and not just sports but other sort of intense activities, right? Um, such as dirt biking, such as ATV riding, things like this that sort of increase our risk of injury. Snowboarding, skiing, things like that. And so we don't necessarily see a consistent pattern for income with every single injury type. And I think it would be unreasonable to think that we would, right? In terms of education, we see here it's kind of clear. So compared to having no high school at all, those with a high school diploma, but less than a bachelor's degree, had about the same risk compared to those with no high school, just slightly elevated. This can be once again for a number of reasons, but we do see a protective effect for those with a bachelor's degree or a higher, right? So those with bachelor's degree or higher would have slightly lower risk of unintentional injuries overall. Maybe not necessarily surprising, as some injuries are informed by our decisions, right? And I tend to think that there's maybe more injury prevention messaging sort of locked in throughout our education and stuff. So there are a number of reasons why this could be the case. Now, in terms of gender, we see clear gender disparities in most outcomes. So this will come as little to no surprise that males experienced higher risk of injury attributable emergency department visits. This is so consistent in the existing literature, and it's due to a number of different reasons. It can be why, how men experience their social environment. They tend to externalize their feelings and engage in riskier behaviors, right? And so this is quite common in the existing literature. In terms of immigrant status, we do see a slightly reduced risk, but this is among immigrant populations. This is not statistically significant, but this is also something that we consistently see in the literature, is that immigrants tend to have a lower risk of injury when compared to non-immigrant counterparts. Now there's some interesting ethnicity dynamics here. So we see that all ethnicities, when compared to white folks, have a lower risk of injury, of unintentional injury specifically. And then compared to single folks, married folks have a lower risk of injury, not necessarily surprising. And then those folks who are separated, divorced, or widowed have an increased risk of injury. And so these are, sort of intuitive. We can reason most of these out, and it is really interesting. Next slide, please. So I just wanted to show you here that this is for the outcome of falls, so a specific injury type. Now, in terms of income, we see not massive differences between the injury groups or in comparison to lower income. Sorry. And this is because falls don't tend to be as socially patterned or as income dependent compared to other injury outcomes, right? So we might see differences for things like violence or self-harm or even concussion, right, where we might see that inverse slope. But truly for falls, it tends to be a little bit less socially or less income dependent. For education, we see sort of the same results that we were seeing for gender. Once again, males have slightly higher risk. These are all sort of consistent with the existing literature. And then I would like to point out that folks who are married compared to single have a lower risk of falls. or emergency departments owing to falls. And this can often just be because they have someone there, right? Someone who they're married to, who's sort of looking out for them or is able to help them up if they were to fall down, rather than, for example, calling an ambulance. Whereas those who are separated, widowed, or divorced have a higher risk of falls. Next slide, please. We see what we see here, and I won't go through the whole table because I am sort of seeing the time here. But in terms of intentional injuries, we do tend to see that these are much more socially patterned when compared to unintentional injury types. And so, of course, income is associated with self-harm, with assault, and these are quite intuitive. Those folks with the bachelor's degree have, sort of exponentially lower risk of self-harm and of violence, right? So these are things that we do typically see in the literature. It's not necessarily a great thing, but it is typically true that intentional injuries are socially patterned. If we can go to the next slide. Okay, and this is one specific intentional injury type. So this is for violence. Once again, we see that with higher levels of income, there are lower levels of violence and assault. With higher levels of education, there are lower levels of violence and assault. Men are at an increased risk of violence and assault. Immigrant populations at a lower risk. Some ethnic groups are at a higher risk compared to white folks when it comes to assault, which is particularly interesting. Those folks who are married are at a lower risk of violence or assault, and and similarly, those who are separated, divorced, or widowed are at a lower risk compared to those who are single, never married. Next slide, please. So essentially what we found is that some outcomes are a bit more socially patterned than others, but all had some indication that social determinants of health played a role in injury-attributable emergency department visits. Next slide, please. This second study, I'm gonna go a little quick through this one, but this is essentially looking at the area level factors that contribute to rates of injury across the province. Next slide. So one way to characterize the social determinants of health is through area level data. So what we did is we looked at Alberta Health Admin data and census data at the forward sortation area level, which is actually just the first 3 digits of your postal code that sort of identify a community that you live in or a neighborhood that you live in. We know that folks within neighborhoods have sort of similar risk profiles, maybe similar behaviors, similar attitudes, and those can inform injury rates. Right. And so this data is not necessarily generalizable to individual people, but more so about the social environment of given neighborhoods. So what we did is we looked at mechanisms of injury by prominent markers of social inequity at the area level. Next slide, please. So in terms of social inequities in injury just generally, what we see is that, we looked at a number of different social factors such as income inequality, so the gap between the highest and lowest earners within a given area. Typically, higher income inequality is associated with worse outcomes, right? We look at the proportion of lower income folks, the proportion of renters within an area, the proportion of folks who are receiving government transfers, proportion of visible and minority households, median household after tax income, lone parent households, the percentage of recent immigrants within a neighborhood, and of course time, just to see if everything's sort of consistent over time. And what we see is that different markers of social inequity had bigger impacts on injury risk overall. So one, for example, that I'd like to point out is that the proportion of recent immigrants within a neighborhood is associated with an increased rate of injuries, which is really interesting because we in fact saw the inverse in the individual level data. So this is something that we need to really always be thinking about. And so is it that in these areas with higher immigrant populations that it's the non-immigrants that are getting injured or that are being targeted and things like that? Like these are sort of some contextual things that are particularly interesting. Sort of unsurprisingly, we do see that that higher income inequality is associated with a greater risk of injury overall. And this is more so like owing to probably the social connections, right? Because if you live in a higher income inequality area, you might feel a little bit, if you have a little bit less than everyone else, you might feel a little bit worse or be comparing yourself. And that can sort of manifest in a number of different ways and increase your risk of injury. Whereas if you're a higher income person living in a high income inequality area, if something happens to you, how likely are you to go to your neighbors, right? Those people who feel maybe a little bit different than you, to ask for help, for example, or ask for support, or ask for a ride, right? Ask for a cup of sugar. It's this concept called informal reciprocity, where you can go to your neighbor's house, knock on the door, and say, "Hi, can I borrow a baking dish?" It's the degree to which you're likely to do that in more unequal spaces, right? And so in more unequal spaces, we see increased risk of so many adverse health outcomes, and injury is not, and injury is one of them, right? It's not necessarily unique, but it's important. Next slide. Now, this is sort of a summary slide showing which factors were associated with which types of unintentional injuries. So there's a number of different types here, but I'm really just going to, I think, flip to the next slide to show you that that overall we see in both the area level analysis and in the individual level associations between social determinants of health and specific injury types, that there is a relationship, right? So based on this evidence, it seems clear that social inequities can impact injury risk. And it seems clear that if we're able to focus and mitigate those social inequities, that maybe there's a way that we can reduce injury risk in ways that are not necessarily traditional injury prevention programming. Next slide, please. So if we're taking this one step further and we're thinking about supports for folks that are at increased risk of injury, maybe we're thinking about things like social supports, right? And community engagement, community programming to build those connections. You can ask for help when you need to, and to really build communities that can support one another and ultimately foster positive health. And we can also think about different policies that we can implement in those spaces where folks are most at risk for different types of injury, right? And once again, things like traffic calming or helmet bylaws. Next slide, please. But when we're thinking about each of these things, when we're thinking about supports, I'm sort of urging folks to consider that maybe improving social capital, so things like offering more education, um, reducing distance to clinics or reducing barriers to accessing clinics, improving care, right, and our perceived ability to access care would be really excellent supports for reducing injury risk, because they target some of these social determinants of health that could potentially be sort of root causes of the risk of injury. And then in terms of policy, I'd urge us to think a little bit broader and start thinking about different ways that we can reduce inequities with an ultimate goal of reducing injury risk that has such a high burden on the public health care system. And so things like, reducing income inequality through minimum wage increases, that can be super helpful. In terms of, families where they need additional supports, maybe childcare subsidies. These are great ways to reduce inequities that ultimately can potentially have an impact on injury risk and severity and the way that we get better post-injury, that we don't necessarily think of as intuitively associated with injury, but I think that there could be steps taken here to better understand that these social policies might have an impact still on our injury risk. Next slide. And so why does this matter? So addressing the root causes of injury might be cornerstone for injury prevention and for reducing inequities in injury, right? Reducing this or mitigating this idea that injury is not equal and affects different groups differently, and more so for some more vulnerable groups. So understanding the social determinants of injury can help us to identify key points for intervention, but also key priority groups for intervention if we're seeing in specific demographics that injury risk is higher, or there's something that's just not quite adding up. Next slide, please. And it also matters because injuries impose a large burden on the healthcare system. And this has been, relatively stable over time. We already know that this huge chunk of dollars and time and healthcare and support and just general unwellness is being imposed on us each year. And we have to start getting creative with the programs that we're implementing and the policies that we're implementing with it with an aim to ultimately improve the health of our societies and reduce injury. Now, this, of course, is important because injuries are a leading cause of death and disability. And because injuries are predictable, they are in fact preventable. And so anything that we can do to reduce injuries and shift that population level risk associated with social inequities, I believe is a major step forward in the injury prevention sphere. Next slide. And that's it. So I'd love to hear if anyone has any questions or anything like that. And I just really appreciate you taking the time to listen to me.
Thank you so much, Claire. We can open the floor for questions. Sarah, if you see anybody in the chat, you just let us know.
For sure. I was just going to put a note in the chat, but yeah, if anyone has any questions, feel free to unmute yourself. Cynthia did put in the chat that there was an interesting Alberta study abstract looking at the built social environment during winter. So it looks at the winter walkability tool, which allows trained researchers, planners, and policymakers to objectively assess the micro-scale winter pedestrian environment to inform policies and practices that can promote physical activity. So there's a little bit more information in there.
Yeah.
And then they just said, thank you for the wonderful presentation, very insightful and wise.
That's awesome. I really appreciate this comment. I've opened this page in my browser so I can take a look later. I have a friend in engineering who's very interested in how we quantify the built environment and injury risk, and so I'll have to pass that on to them as well.
Amazing. Thank you for sharing. Yeah, does anyone have any questions?
All right, we would like to,
There is a question in the chat.
perfect.
Drew said, thanks for a great presentation, Dr. Benny. I have a question regarding the other category in ethnicity. How is it identified further?
Yeah, thank you so much for this question. I'm really glad that you brought it up. So the categories for ethnicity that I used um, were in line with the existing study. So I think there was a category for folks from like for Asian, Hispanic or Latin American, Black, white, and then that other category, which is really sort of a sticky spot and truly not representative of all that other represents, right? Especially in the Canadian context, that's so many that's so many ethnicities that are sort of lumped together in one. The fact of the matter is that I grouped it together this way because of limited numbers of events within some communities and trying to reduce the risk of being able to identify any folks. So I do my work through what's called the Research Data Center. So it's part of the Canadian Research Data Center Network, which has really strict rules about vetting. And so their major concern is ensuring that no one is identifiable based on any outputs that we release from the research data center. So in order to have high enough counts to release this data, I did have to group some folks together. I would love to also note that for Indigenous folks in particular, based on the existing literature, we know that a lot of these groups have an increased risk of many types of injury within like CIHR, the Canadian Institutes for Health Research, their ethics component. It's called TCPS2. and we're not meant to release any data related to Indigenous folks without the active participation and buy-in. And it's that, I think that's saying nothing about us without us. And so those statistics are not included in this work, because I haven't. Yeah, I think that would be sort of a separate thing in and of itself. And right now I'm working on building relationships with Indigenous communities to improve this sort of line of inquiry, but I would not feel comfortable, sort of speaking on that without having that sort of buy-in and just general engagement with those communities. So I did want to note that as well.
Yeah, right now I'm just seeing a lot of love in the chat, just people thanking you for the
Very nice.
presentation. Um, I'm not seeing any more questions at this moment.
Great. Well, we would like to remind you that a recording of this presentation will be available on our website. If you're not already a member of the link, it is an Atlantic Children's Injury Prevention specific community of practice. You can scan the QR code here on the screen, and our presentation will also be available on there, as well as any future presentations, which we do have one coming up November 19th, and this is with Dr. Barbara Morangello. So save the date for that one. Again, on the community of practice on our website, the registration is all there as well. And thank